Hello, everybody. This is Dr. Darshan Shah, the host of the Next Health Forefront podcast. And today I have a very topical, timely podcast about the status of COVID in the hospital system. And the reason I'm doing this is, COVID-19 is spreading. We all know it's out there. I think we all maybe know one or two people that have gone to the hospital, or maybe not. And what I found is that most people, physicians included, don't really have a full understanding about what's going on once you get to the hospital. And number one, I think we all know when we need to go to the hospital, when you're too short of breath, when you're having a really high fever for a long time, if the doctor says you need to go. But then what happens? How many of people get discharged from the emergency room? How many people end up in the ICU? How many people actually make it? What treatments are working? These are all big questions that I think I have the perfect guest to answer all of them. So I'm going to introduce Dr. David Ning. Dr. Ning is a physician and a friend of mine, and he has a unique insight in that he is the director of the ICU at his hospital. So let me give him a quick introduction and a little bit of his background. Probably won't do him good justice on this, but I'm going to try anyway. So Dr. Ning got his medical degree from St. Louis University. He went to med school around the same time I did, same state. He was down the street. I was in Kansas City, and he completed his residency and came to Los Angeles to do a fellowship in pulmonary and critical care medicine at Cedars-Sinai. He then went on to become board certified in internal medicine, pulmonary diseases, and in critical care as well. Since his board certification, he's been working in the intensive care unit. He has won many awards, both for his compassionate care and his contributions to medical education. He works closely with heart, lung transplant people. He takes care of people with severe lung illnesses all the time. That's his specialty. He's a clinical instructor of medicine at the UCLA School of Medicine, and he's one of the smartest and most humble people I know. So I'm excited to have him on our podcast. He's a true expert battling on the front lines every single day here in Los Angeles, and I think he'll clear up what's going on in the hospital picture of this disease, what's going on in that particular segment. So I'm going to launch right into it with Dr. David Ning. David, so tell us a little bit about what you're seeing as far as people coming to the emergency room. What kind of people are coming? Or is it just sick people that are coming, or all sorts of people coming? And are a lot of these people getting admitted?
So the emergency room experience is very different now because of with everything that's been in the news. Like, people are really trying to avoid using the emergency system because they have a feeling that a lot of people with COVID-like illnesses are going to be going there, so they want to avoid those situations. So I will say that a lot of people that come in are with a cough, with a fever, and they've been trying to be at home for a long time or managed at home by their physician, and now they're sick enough where they're coming in for this department. That's one group of people. And then you have, life goes on. Then you have the standard people that come in with the normal everyday ailments, from chest pain to other kinds of pneumonia to congestive heart failure. And then you have the transfers from the nursing facilities that are coming in for, I guess, their standard illnesses as well. But ultimately, those people are having a higher predilection of COVID that we're seeing. So It's standard, but there's probably more people that are coming in with these viral type of illnesses that we have to rule out for COVID. And that's really an increasing population of who's actually coming into the hospital.
Wow. So, that's pretty incredible to just think about that, because I remember from my time in the emergency room, almost half the people you saw were not really sick people. And I can't even imagine how busy it is when everyone is truly sick that's showing up. It's the emergency room the way it's supposed to be used, right? For sick people.
Actually, it's not just the emergency room, but it's the whole hospital. The hospitals have prepared for this. In California, we've had the luxury of time and preparation. We did not get a surge. We did not get a huge influx of patients right away. So we've spent the last couple of weeks trying to figure out how to triage, how to take care of all these people that potentially could be coming in. So our ER has a separate area for all the people that they're worried about with a COVID infection, so they can kind of quarantine them already right from the get-go. So we have tents, we have areas that people go to. And then our whole hospital has shut down everything elective. So all the orthopedic surgeries, everything elective has been basically canceled for the last several weeks. So our hospital actually is emptier than it ever has been only because all of these normal procedures that commonly occur have now all been delayed, from endoscopies, colonoscopies, to cardiac studies, to surgeries. So it's an increasing proportion of COVID patients that are now coming into the hospital.
Wow. Interesting. So people show up to the emergency room, and the hospital's kind of reserved for sick people with COVID and sick people. So that's actually speaks a lot for how prepared Los Angeles is to empty out that, kind of non-sick elective population. I think is a great first step that, like you said, we have the luxury of time to do. But so going back to the emergency room, though, what percentage of people are you guys actually admitting to the hospital? Like, I'm sure there's still a certain percentage that are still going home after maybe a breathing treatment or something.
I don't know if I have the answer to those questions, to that question right there. I know that there are definitely it's not a huge number of patients that are actually getting admitted with this in the grand scheme of things. Our experience in California and Los Angeles is much different than what's happening in New York. So we have like this kind of linear type of growth. We don't have this exponential growth that they saw in New York. So when it comes to the percentage of patients, I don't really know the percentage, but I can tell you that most people do not get admitted. Most people are still probably sent home to manage their symptoms at home. The ones that are sicker, that are at higher risk for like decompensation, or the ones that are short of breath that need oxygen and need a little bit more monitoring, are the ones that are admitted. And that actually, again, it's been a steady number, and we have not seen like this explosive, like overwhelming growth that they have in New York and in New Jersey.
I mean, that's pretty incredible too, because like you said, out there, I think that was one of the first hit areas, and they had that exponential curve. Sounds like we've actually flattened that to where you're seeing actually linear numbers of people coming in.
Yeah, we're hopeful. We don't know if we hit the plateau yet. I don't think you're going to know until after you hit it and start going down. We're hoping that, if we haven't hit it, it's going to be in the next couple of days, and we never see the surge that they saw in New York. I mean, everyone's prepared for it as much as we can. I mean, I don't know if you can fully prepare for that many people coming in at once. But we certainly have, I think, a lot of infrastructure in place so that if there are larger numbers of sicker people with COVID coming in, we actually can take care of, hopefully, most of them, if not all of them.
That's fantastic. So are there like criteria for admission right now that have been developed, or just as a general feel from what you're seeing people getting admitted for? Is it mainly people that aren't able to maintain their oxygen saturations? And that kind of it?
That's mainly it. So the main issue is going to be respiratory status. So people that are short of breath are going to be the ones that get admitted. And the easy objective measurements are like, if you need oxygen, that's a pretty good sign that you should get admitted. Other things that we look at, because we have like criteria and algorithms, like we will easily deviate from them just to make sure that people are taken care of and get the help they need. So, anyone with like altered mental status, anyone that is, have multiple comorbidities, anyone that has like really a lot of significant inflammatory markers, we oftentimes will elect to admit and watch. Although we are trying to manage as many people as we can at home.
Got it. When you say inflammatory markers, which ones are you looking at specifically?
There's a couple ones that we look at. So the people who have this infection have certain characteristics that honestly, like we just don't really see. One of the things is on the blood panel on the CDC, they have this like relative like lymphopenia. Like people have just low lymphocyte counts. So that's not really a inflammatory marker per se, but that's a laboratory that we oftentimes will look at. Some of the other things that we see are their ferritin levels are incredibly high. Their D-dimers are elevated. Their CRPs are elevated. These are all inflammatory markers. Their LDH is elevated. And then there's a marker called procalcitonin that a lot of times what we use to help us to determine if someone has a pneumonia or a severe infection, and that number tends to be very low. So those are some of the markers that we look at.
That's interesting, really interesting, and that is different from what I remember being in the emergency room. We would rarely look at some of those markers, but it sounds like you guys are finding these markers now.
Yeah, we are. So these are some of the criteria that we use for not just admission, but to monitor someone to see how sick they are, and then also for some of the medications that we give and the trials that we're on.
Got it. So are you, like, in your feeling, are you seeing more men than women, more people that are elderly? Like what is the general characteristic of who's getting admitted?
There's men definitely get much sicker. There's no doubt. I think in China, the initial numbers were like 56% of people getting sick were men. I think in New York, it was probably a little bit higher than that. I think here, when we look at the characteristics of the ones who get sick, it is disproportionately male. Now, we have a smaller sample size, so it's always hard, like, is that just a sampling error or is that really characteristic of what's going on? But I think that is definitely consistent with what everyone else is seeing. If there is a predilection for men getting sicker with this.
Got it.
It does tend to affect older people. Older people, the population of people that are sicker in the ICUs are definitely older, but we see younger people as well. People with no comorbidities that you're just like, why did this person get sick? And why did this, seemingly the same person, for the same age, same, like no medical issues, just have minimal or no symptoms. And we cannot tell. It's very difficult to tell. Like who's really symptoms or not.
Yeah, and I think that's important for people to know because I think a lot of younger people are being a little bit cavalier about their social distancing because they're going under the assumption that, it's just an old person's disease, like you have to be old and sick or have diabetes or, some other diseases. But younger people can get sick too. And you guys are seeing surprise cases of people that are seemingly young and healthy that are getting admitted and getting really sick.
Definitely. There's no doubt that younger people are getting sick with this as well. I mean, there's reports. I mean, it's not, the numbers are not huge. So it's not like it's like H1N1, like certain other infections had affected like a lot of younger people. This is not one of those. It definitely disproportionately affects older people, but there's no doubt that younger people can get sick as well.
Wow. Yeah. And then also, like, I talk to a lot of just, executives, like 40-something-year-old men that are probably a little bit overweight. They probably don't sleep well. They have some sleep apnea. They eat terribly. Maybe they smoke every once in a while. I mean, what do you think about that type of patient profile?
I will say that definitely being overweight is a risk factor for developing severe disease process. That adds to the list of like a comorbidity that you're going to have.
Right.
So being overweight, I think any kind of participating in any activities that can potentially induce lung injury is probably going to be a risk factor. It's always hard to say because a lot of times we don't know if they vape, how often they vape, if they smoke. I think those are all risk factors. I mean, the inflammatory response that people develop from this infection is really never seen before. It's really overwhelming.
Wow.
And younger people tend to have a more robust inflammatory response. So, when these younger patients, or when these younger people actually get sick, it's very striking, some of the numbers that come back.
Wow. So vaping too, right? You mentioned vaping quickly?
Yeah, absolutely.
Yeah, vaping.
Already we had noticed some problems with vaping, just in younger folks coming in with this like non-specific kind of lung injury kind of pattern. We've already seen this, and I'm sure that this is going to get augmented with the COVID-19 infection.
Yeah. So when someone gets admitted, in general, what's their hospital course usually like if they're, if they don't get sicker? Once they get admitted to the hospital, what are you seeing people go through? How many days are they there? How sick do they get? And then when do they go home?
So it's highly, highly variable. So what people are hearing is true. The overwhelming majority of people that get this infection have minimal or no symptoms. In Iceland, they did a quick analysis and they realized that 50% of the people that tested positive for this had no symptoms, were completely asymptomatic. The vast majority of people that get sick with this do not have to go to the hospital.
Right.
I would say that it's upwards of probably 85 and even higher percentage of people that get this infection do not need any kind of medical attention or hospitalization.
Right.
There's probably in the teens range, like 12 to 15% of people that do get this infection that need medical attention and will ultimately get hospitalized.
Wow.
You probably have somewhere about 5% of people that get sick enough to get hospitalized and require like ICU care.
Uh-huh.
And then you have probably around, it's hard to know, but the quoted numbers are anywhere from like 2 to 2% actually will pass away from this.
Right.
So that's why it's kind of variable. So most people that get hospitalized don't have to get to the ICU don't have to get intubated. But about 5% of people will get really, really, really sick.
Right.
So if you don't have to go to the ICU, we watch you get better. We do give you some empiric treatments, and you're able to go home. Some of these people go home to quarantine for a couple more days so they can completely recover and go about their lives. Of the ones that go to the ICU, the recovery is very, very protracted. Once you get that sick from this, it takes a long, long time. And that's why, like, we see all the needs for like ventilators, because the people that actually get sick enough where their breathing fails and they need a breathing machine, they need to get intubated, they need mechanical ventilation, they tend to stay on the vent for a long, long time.
Wow.
In New York, the numbers coming out of there are 17, 18 days. I think in Italy it was even longer. So you're talking people that are intubated for quite a long time, and then each day they just kind of add up and keep adding up. So the ICU route is strained.
Got it. So that's really important information. So you're talking, once you're intubated for that long, from what I remember of my time in the ICU, you're getting a tracheostomy, you're getting potentially a feeding tube put in. You're really, you're not just a typical vent patient that's in and out in a couple of days to try to get extubated. You're a real ICU kind of chronic care patient there in the ICU.
Yeah, definitely. I mean, and all the trappings that go along with being in an ICU happen as well. They're sometimes difficult to sedate. With sedation comes blood pressure issues. Because there's so much lung injury, we tend to want to keep these people on the drier side, which means that we should actively try to get fluid off of them, and then you can have kidney issues with it. Some people are having like cardiac injury with this. So this becomes like a multi-system kind of disorder, although it really does kind of begin and end with the lungs.
Right.
It is very difficult. We're learning from like everyone's experience, like how to treat people, but it is a long course. And unfortunately, we tend not to do tracheostomy tubes with these people. Even though it potentially can have benefit for them, we can use less sedation, it's more comfortable. The problem with it is such a highly aerosolizing procedure. A lot of our healthcare workers are going to get sick from that. And I'll tell you, the resources that are going to be in the highest demand are probably not going to be ventilators. It's going to be doctors and nurses that are going to be needed to take care of these people. So that's why, we really can't. We tend not to do tracheostomy tubes if we can avoid it.
I can't tell you how many times I've had the conversation with people, like they want to buy a ventilator for their home just so they can have one at home, just in case someone gets sick and needs a ventilator and the hospital is too full. And I said, my response to that is always like, you have no idea of how massive of a situation this is. I mean, a ventilator itself, you need a respiratory therapist, you need a nurse, you need an intensivist, a pulmonologist, but then you have all these other issues, like you're saying, where you need infectious disease involved, you need nephrology involved, you need cardiology involved. Like, it's a multi-system disease once it gets to the point of being on the ventilator in the first place or something like this, right?
It definitely takes a village. It's constant attention and monitoring the whole time. So yeah, it's not just as simple as like you get a ventilator, you can use it at home, you get better, and then you can you stop using it. It really is it's not a very simple thing to enact.
Right. I mean, out of all the rotations I did through my surgical residency, ICU is definitely the most intense and required the most number of people per patient, I would say, is the intensive care unit. And
absolutely,
that's where I see the biggest deficit is the number of doctors and nurses available to take care of these people.
Absolutely. Again, our experience in California is much different than in New York. When I speak to people in New York, it is just, they know they're providing substandard care, but they have no choice. It's very difficult to triage people. It's very difficult to go like, look, we're going to spend time taking care of these people, but not these people. So they end up really getting spread thin, and they ultimately give everyone less than the kind of care we're used to practicing here. But they have no choice. And that's the biggest difference when it comes to surviving this. I mean, right now, as it stands, we have all hands on deck. We have multiple people looking at these patients in the ICUs. And our survival is much different than what is coming out of New York.
Yeah, yeah, I bet. I mean, and that's what's really an important point here is we have to keep this thing under control in California long enough so that the hospitals can keep up with the number of people required, healthcare providers required, to make sure that people don't start dying from substandard care because there's just not enough people to take care of them. And that's why staying at home is important. And that's why this is going to last a long time, because we have to make sure that, our hospitals don't get overwhelmed.
It does not take much to overwhelm the system. It's
Right.
just like, we don't, with the kind of care that these people need when they get really sick, you can handle 1, 5, our hospital, which is a very large hospital in Los Angeles, 10, 15, probably 20 people coming in at one time. I mean, we don't love that, but we probably could accommodate that. When you do that day after day after day, like it stretches the system, and in time we will not be able to accommodate that. So if everyone gets sick at once, it's going to be very, very difficult. But if we can kind of spread it out, if we can flatten this curve, then people actually will have a chance to survive it.
Right.
Of the ones that get really sick.
Yeah. And I think another very important point is people are coming to the intensive care unit, but they're not leaving for a while too. So that, like you said, keeps stacking on top of itself. And what people need to understand too is the longer someone stays in ICU, the harder they are to take care of. They get other issues as well. So it's not like someone is just off in the corner in the ICU on a ventilator. They're requiring even more potential staff man hours to take care of them.
Yeah, it's constant, and your point is very correct. Of the people that we have hospitalized, there is a large percentage that are in the ICU.
Yeah. So let's go back to the numbers on that, because you said 85, maybe 85% of people, even more, are never going to get sick, but 10% do make it to the hospital. And then is it 5% of those 10% that end up in the ICU? No, it's 5% of people. So half of the people that get to the hospital are potentially going to end up in the ICU.
Probably a little bit less than half. I think that the numbers, and again, they vary, right? So it varies based on like prevalence. It varies based on like, because we don't have a lot of testing. So a lot of this is just kind of estimates. But
right.
I want to say that there's probably like 12 to 13% of people that who get this end up needing hospitalization.
Wow.
5% need to get sick enough to require ICU care.
I mean, that's a huge number if you think about it. Just the number of people that have COVID right now, 5% of them will end up in the ICU. Like, I mean, that's a number that immediately you can tell yourself 5% of the population of LA, even if half the population of LA got COVID and only 5% of them ended up in the ICU, that's a giant number. We don't have enough ICU beds in probably the West Coast to handle that many numbers.
If we did not practice these kind of like social distancing and kind of self-quarantine stay-at-home measures, we would not have been able to accommodate it, but we were able to do it. And that's why the California curve is much different than New York. And we were way better prepared. And not only that, it bought us time so we could coordinate our care to figure out how to best take care of these people.
Yeah.
We have all these protocols in place. We have all these teams in place. So we can plan for a surge. Whereas in New York, it just started and they could never get caught up.
Not to get political here, but I kind of feel like a lot of that has to do with the coordinated care and the some surprisingly early stay-at-home measures put into place by the governor and the city of Los Angeles as well. To me, they seem kind of early to that, which, I mean, do you agree? Do you think that it was, I mean, of course, we all wish it was earlier, but I feel like they actually kind of did a good job with that.
Absolutely. I think that our governor and our mayor shut things down as it's tough. It's what they did was not easy. I mean, there's huge impacts on a lot of different people. And we are actually asking everyone to absorb that kind of impact. And there's a lot of financial uncertainty and things that go along with it in order for our population to continue to thrive. This is for like kind of later benefits. So it's very difficult. But without those kind of measures, without those kind of draconian type of measures of just like stay at home, don't go anywhere, stand apart, the impact on not just the healthcare system, but just in people's lives would be immeasurable. If what's happening in New York, in Italy, or what happened in Italy could have very easily been Los Angeles.
Right.
And then you're talking about like people who are desperate, who, don't have, like, they don't have enough ventilators anymore. That's why California shipped over ventilators.
Wow.
They don't have enough doctors. I've known doctors who are in Los Angeles that have become positive treating these COVID-19 patients that have flown to New York just to help them, and they still don't have enough.
Wow.
And in a large part, we've avoided that because of the steps taken by our governor and our mayor.
Amazing. COVID-19 positive doctors are flying to New York to take care of people there. That's pretty amazing.
Yeah.
I mean, that just tells you the dedication of the healthcare workers. It's just absolutely incredible.
I don't think they can say it enough. I mean, these people, they know that that healthcare workers got sick, and they're right in there. They gown out, but even with gowning out, there's always it's so difficult to put on, not just put on, but to take off the
I remember.
It's so easy to just slip up or forget. But they continue to do it, and it's just unquestioned, especially when they see someone getting sick. Like when a person gets sicker and they need immediate attention, I mean, no one even hesitates. So it's incredible. It really is.
Right. I think we're kind of programmed in that way. Like, when someone's crashing, you just go and do it, whatever you need to do as quickly as you can, because you gotta help. And I know during those times, I know even doing trauma surgery, you just do a quick scrub and you run in because a person's going to die if you scrub for the whole 3 minutes, right? Yeah. So it's the same kind of feeling. You just got to get in there.
We've had to tell people to look. We know what's going on right now, but you have to just wait. You have to put on everything because if you get sick, you're out for a couple of weeks, if not longer, and we can't risk those resources right now. Yeah. But that's the nature of the thought process of what some of these nurses and physicians go through when they see someone getting sick in front of them.
Yeah, it's just so incredible and admirable. So let me talk to you a little about managing COVID versus managing like your standard run-of-the-mill pneumonia that's in the ICU. You mentioned this extreme inflammatory response, and I've been reading a lot about that lately because it some people call it cytokine storm. Some people, tell me a little bit about that and how that's different from what you typically see and why that's so dangerous.
So the first thing is we've never seen so many people with the same illness come in at one time. Even here, where our numbers are much fewer than other states and other countries. It is striking how there's just so many people with that diagnosis. So, I mean, people can have pneumonia. There are different kinds of strains of bacterial pneumonia. You just don't have that many cases in the ICU at one time. People can get a severe influenza infection. And like H1N1, sometimes with like younger kids, and you have a couple sprinkled here and there, but you just don't have the sheer numbers. When we look at some of the laboratory abnormalities, it's striking. We just don't see an inflammatory cascade as high. Now, sometimes we don't really measure it quite as well, just because, we know that with treatment, with time, with some supportive care, a lot of people heal. But this cascade, these laboratory abnormalities are so striking that we use that to try to dictate some of our treatments because the storm that these people go through, something as simple as, I have not seen people with fevers this high. You have people with fevers like 105, 106. You're just like, what is going on? And it's relentless. It keeps going.
Wow.
We do not see inflammatory responses with the standard pneumonia, with the standard influenza viral syndrome that we're seeing with COVID-19.
Yeah. I get the feeling from you, like you're an intensivist, you're in the ICU for years and years of your life. And I get the feeling from you that you're looking at some of these lab results come in. You're just like, holy shit. And it takes a lot for someone like you to say, holy shit. You're saying it over and over again.
It's not like a factor of 10. It's like a factor of like 100. You're like,
wow,
what's going on here? Like, what are these numbers? Like ferritin numbers in the tens of thousands. You're like, that's a lab where if you get like a couple hundred and you're elevated, someone who's really inflammatory, he gets like 1,000. And these people are having like 10,000, 20,000, 40,000. I mean, I didn't even know our labs could measure that far.
Right.
They're highly, highly inflammatory. And they also have problems with the coagulation cascade. They get very, very clotty.
Yeah.
So there's a lot of blood clotting issues that come along.
Right. It kind of reminds me when I was in medical school. I think you were in medical school probably around the same time I was. I remember when HIV first came out, and the whole hospital had HIV wards, and everyone was looking at laboratory results and just, what the heck is going on here? Is just, you just get this feeling as a physician of just complete helplessness almost sometimes, that you're looking at someone and you just, with all the tools available to you, just feel like you can't help them sometimes. And I can't imagine what it's like right now. I just get that feeling of just this kind of knot in your chest thinking about it.
We keep thinking like they're going to turn around, they're going to turn around, they're going to turn the corner, and they just don't. They just wait. They wait. They plateau. They stall out. But a lot of them do turn the corner. So I don't want to leave people with this, like, get it, you get the ICU and then you're done. We've been able to really get people extubated. We have a lot of people that are in the process of healing. And again, our experience is much different than New York, purely because of the numbers and the resources. Right. So, people that probably would expire or not have done well in New York, we're actually able to buy them time to heal.
Right.
So they do get better, which is something that absolutely happens.
So that's a really important point for people to know too, is that if we have the luxury of time and appropriate staffing in the ICU, then people will get better and they will eventually get extubated and hopefully go home. But if we don't have that luxury, by people going out there and hanging out at the beach with their friends and having parties, then we're not going to have that luxury and people's family members will die.
Yeah, absolutely. So some of the numbers that we hear coming out of New York, and a lot of these are not huge aggregate numbers, but in certain individual hospitals, certain individual places that are really stretched thin, they're having upwards of like 80% of people that get on a breathing machine do not ever come off of it alive. So that means 4 out of 5 people that get intubated ultimately die. I mean, that is a horrifying number.
Horrifying.
Our experience is markedly different right now. So if we're able to kind of maintain the numbers and have this kind of like linear rather than exponential growth in cases, hopefully we'll be able to kind of maintain the survival for these patients that get a severe infection.
In the ideal scenario, say you had an ICU of 10 beds, all 10 beds have COVID patients in them that are intubated, and you don't get any more at all, and those 10 people have all the care available to them, how many of those 10 would go home?
That's tough. The mortality for this is kind of all over the place.
Yeah.
I would say that you are going to get people that just do not get better.
Right.
That's,
of course,
unfortunately, regardless of who's taking care of them, how many people you have taking care of them, and the kind of therapies you're able to enact. Like, there's just some that do not survive. But I will say that, if of those 10, greater than 50% should be able to survive. And I'm hoping that we get that number to where the mortality is going to be less than 50%. Can it be 40%? Can it be like 30%? That would be ideal. But those are kind of the loose numbers that we're looking at. So if we can get it less than 50%, I think we're going to be doing pretty well.
Yeah, that's such a huge delta between, New York 80% not going home and 40-50%. I mean, that's a big swing. And like you said, it's a luxury of time. The more time we have, the more therapeutics we can figure out, the more that we can keep someone on a ventilator and have room for others as well. So yeah. I want to jump over to therapeutics real quick, if you don't mind, because I know you're on a lot of research studies right now, and you've tried a lot of different things. Are you seeing anything out of your standard treatments for this type of thing that's working?
It's hard. I mean, that's the dangers of just like anecdotal data.
Right.
It's, you don't know if you're actually seeing the full picture. I don't know. The standard that we've enacted for people that come in is, if you are sick enough to be hospitalized, we do give you a trial of Plaquenil and azithromycin. I will tell you that most of us think that it's going to have a very modest benefit. And to even go further, I think most of us think it's probably going to have no benefit, but modest at best. If people do get sicker, there are other therapeutics that we do enact. And we actually, Jonathan Grind, who's a colleague of mine at Cedars, just had a big paper in the New England Journal coming out on one of the medications that we've been using that looks like there's going to be therapeutic benefit. But those are for the severely ill.
Wow. And what about these immune globulin therapies donated from the blood of people that have recovered from the virus?
So that's starting now. And there's a couple of different trials going on. And one is a prophylaxis for people, and the other one is for when they get severely ill. So right now, we haven't started that here only because we haven't had a lot of patients that have been positive for COVID-19. It's a convalescent plasma trial. But I think that in the next couple of days, we're going to start actually collecting plasma and then starting some of the treatment. So, that has worked in the past, like for severe viral illnesses or illnesses in general. Like this convalescent plasma has worked in the past. I think in New York, with the sheer number of cases, they've already started those trials. So those are all things that are underway. That one looks like it has a potential for a huge therapeutic benefit.
Okay.
But there's not going to be a panacea. There's not going to be like, take this, you're going to be fine. There's nothing like that.
No. Even with plasma therapy, I would think that if you don't get it soon enough, and it's still not going to work on a lot of people. And once you have that inflammatory cascade, it's starting, and you have all that fluid and consolidation in your lungs and all that all happening, it's probably less of a chance of it working.
Yeah, so those are the things that we kind of debate and argue about, like when should we give it, when is appropriate. By the time they get to the ICU, is that already too late? Is it really an infection problem, or is it more of like the inflammatory response to the infection problem? Is the infection still driving it? So these are like little things that all of us are arguing about in terms of like when to give it and what to do. But those are concerns.
If someone has recovered from this, should they seek out like donating their plasma right now, or is there places for them to go? Yeah,
there are. I know the Cedars one is going to go online soon. So when I get like the website, we'll let you know. But there are places. So there's certain criteria. So, and again, this is so fluid; it changes all the time. So I'm not exactly sure, but you have to have obviously tested positive for this. You have to have some degree of convalescence. So it's not just because if you're positive, you don't. It takes a while for the antibodies to develop. So there's going to be some time of convalescence before we're able to actually procure those antibodies from you. And then there's different criteria that we use. So one of them is if now the antibody testing is coming out. If you have an antibody test that shows that you actually have produced those antibodies, that's another criteria we use for someone to allow someone to donate. Those will be all live soon.
Got it. Great. So if anyone's listening and they've recovered from the disease, they have IgG antibodies supposedly in their blood test, they should just search online, especially at the big local hospitals here in Los Angeles, but also the Red Cross, I would imagine, is also running some collections as well. I heard they were collecting as well. So it's important. I think it might be one of the main, probably one of the only therapeutics that show to really work with this thing. So hopefully we can get that online soon.
I can pass it along. I don't have it with me right now, but I know that at our hospital, our collection and our protocols and our trials are going to go on. Like they've already started, but actually actively collecting probably sometime this week.
Good. So I'll put that in the show notes for this as well. So are you guys testing people in the hospital for COVID? Are you guys doing immune globulin testing or nasal swab PCR testing?
So most of it's still the nasal swab PCR testing. Our antibody testing is probably going to start next week. Okay. So and we're probably going to start with some of the people that have to take care of these patients. We're going to have both testing soon. It's still not enough. It's incredible. I hear we cannot get it back fast enough, and we cannot test enough, even in the hospital. It's still
healthcare workers especially, like they need to get tested. I mean, there's such a huge huge benefit to knowing that you're immune to something. So you can just, you don't have to be constantly fearful as
Yeah.
well. Would you even think that, healthcare workers that are immune to it would have less protocols around wearing PPE, or how would that go?
That's a good question. So there's still some concerns over possible reinfection.
Right.
We have seen that, but we if this behaves like any other virus that we've seen, once you get it, you are probably going to get some degree of immunity for some time. Anecdotally, there are some case reports of people that have gotten reinfected. So I don't think it's going to be as simple as once you get it, then you can just go in there without any kind of protection. But yes, I mean, I myself would feel much more comfortable if I had antibodies and taking care of these before I took care of the patients.
Sure. How are the hospitals doing with personal protective equipment anyway, with masks and gowns and?
It's different. Before this occurred, I mean, it was liberal. You could get gowns, you could get masks. You're using multiple masks. Like, people really didn't think twice about it. Now it's definitely we have them. I don't want to say that they're rationed, because if you need a mask, you get a mask. If you want an N95 mask and you're doing like an aerosolized procedure, you have a patient under airborne precautions, you get an N95 mask. If someone is taking care of a patient that is a known positive in the ICU, and they want one of these, positive airway devices, you can get one of those. So we have them. We're okay. But I don't want to say that they get rationed, but the hospital is very cognizant of providing these masks. So before they used to be on like everywhere you can get it. It's not quite as simple anymore, but if you want one, you can get one.
Got it. Good. So along those same lines, I mean, as far as number of doctors, ventilators, number of personal protective equipment, do you think here in Los Angeles, we're ready for the peak when it's going to happen? And when do you think that peak is potentially going to happen?
The numbers are all over the place. So to the first question of, are we ready? Do we have enough? Yes, we're going to be fine. We have enough ventilators. We have enough ICU beds. We have enough personnel. We have enough equipment to take care of people. Can we keep doing this? Like, the issue is going to be, so everything looks great, we start opening up again, or people start opening up again, and then it just happens again, and do we have enough to withstand like this repetitive insult to the system? That's when it gets kind of dicey. But right now, if everything goes according to how all the recent modeling has shown, Los Angeles, California is going to do very well. We have more than enough to take care of everyone that potentially can get sick. In terms of the peak, initially, like, I think a lot of people think it's going to peak in a couple of weeks in late April and potentially like early May. Some people think that it's going to peak probably in the next week or so. So that's what we're hearing. I think it's probably going to be somewhere in between. You're not going to know the peak until after you've hit it, and then everything's plateaued. So every modeling is just an estimate. It's probably going to be relatively soon, meaning like in the next couple of days to weeks. It's not going to be. I don't think it's going to extend into like late May, as long as everyone keeps doing what they're doing. If social behavior changes, then all this modeling goes out. So,
right.
But right now it looks like it's going to probably be upon us. I would love to say that we peaked next week, and everything has kind of plateaued and goes down from there.
Yeah. So that's approximately 2 months or so since the stay-at-home order. So to me, a peak means, you had this 2-month time period, you're at the peak, and now we have another 2 months after for this thing to like go downhill again, right? And a lot of people are asking, well, when are we going to get back to normal life? And the date in everyone's head right now is May 1st. I don't think that's realistic. What are your thoughts?
No, they've already extended it. I think in Los Angeles, they extended it from to, I want to say, May 15th.
Yeah, I think you're right.
So they've already extended it. It's again, this is not. It's hard to predict. Like, there's so many different aspects that affect when the peak is going to come. And a lot of it's social behavior. And like, how do you actually maintain that? How do you actually make sure that people are doing the right thing? And you won't really know it until after the fact. So, once it hits a peak, it's going to be a couple weeks. I will say that April is already gone in terms of like getting back to normal. I think most of May is probably already gone. I think what is going to be normal is going to be very, very different,
right,
in the world. And I don't know. I don't think we're going to get back to where we were before for quite some time. Not just months, but years, something like that. Yeah. I think behavior is going to change dramatically.
I agree with you. I'm 100% in agreement. So how do you think this, I mean, the staff of the hospital, you're in there every day. How do you think they're holding up?
I think they're okay. I mean, there's definitely fatigue that's setting in. I mean, it's, after a while, you just, the stress of taking care of these patients just kind of wears on you. And also just taking care of the same thing every day wears on you. So, but as it stands, like, everyone is still very upbeat. Like, we everyone thinks we're making a difference. We know that and we see people getting better. And as long as those things, continue to happen, like, healthcare, we can keep doing this like indefinitely.
Right.
But on an individual basis, there's no doubt this has led to a high degree of stress amongst, especially the nurses. I mean, as doctors, we might go in there, we might see the patient for a short amount of time each day, maybe. The nurses are in there, if not all day in the ICU, like multiple points, and that is just, and they read everywhere, people getting sick from this, and that adds a huge amount of stress to their overall everyday life.
Yeah.
Right now, I think it's okay, but hopefully it'll stay okay. But if this keeps going on indefinitely, I think there's going to be a lot of emotional fatigue that comes along with taking care of these patients.
Right, absolutely. We worry about the nurses and everyone in the hospital. I think it's that everyone's working all the time, and I think all the rules about 8-hour shifts and 10-hour shifts and so many days a week have gone out the window for the most part, right?
Yeah,
everyone's just working.
The amount of here it's different because we didn't get the surge, but the amount of meetings and coordination from the physicians, the nursing, like people just did it all hours of the day. And I will tell you, like, my division did an incredible job. Like the heads of our division, the head of our leadership, they were unbelievable. Everyone knows their role. Everyone feels well prepared. There's layers upon layers of thought that went into this. If the surge happened, if more people come in, like, everyone really is very confident that we'll be able to take care of certain things. But that was, how do you measure that kind of time? I mean, that's all hours of the day. That's like emails, phone calls. Like, there's no like, it's, if someone has a thought, I mean, they fire it off. And this is like almost like 24/7 type of activity in planning for this. I don't think people even realize how much time was spent in doing that.
Yeah, I feel like it's like kind of like a wartime activity. When you go to war as a soldier, you're not off the clock at a certain hour. You're constantly fighting a battle or worrying about the battle. It's kind of like that for our healthcare providers right now.
It is, but it's great to see because they've done such a good job so far. It's nice to actually see some of the planning make a difference, and it absolutely has in terms of patients doing better, in terms of coordinating the care to like reduce exposure for the healthcare workers, and also just reducing exposures to everyone in the hospital. Like it's great to see. It's all been worthwhile. We're lucky in that regards.
Right. Well, certainly in a bad situation, everything that you've told me is actually kind of encouraging. To hear how prepared we are in Los Angeles, to hear the level of coordination and dedication of the healthcare professionals, and that we are not going to be in as bad of a situation as New York. I mean, that's all very encouraging news, but it's all so dependent on the people, the listeners of this podcast, the people out there telling everyone that they know who hear this to do their part and socially distance, and don't believe all the ridiculous crap about this being due to 5G or political reasons or whatever. I mean, this is real, right, David?
Yeah, it's real, and it doesn't take a lot to overwhelm the system. You know, it just doesn't take a lot. And we have a huge hospital that's ready, but you get 20 patients, and that's a lot, right? You get 50 people in one day, all hell breaks loose.
Right.
I mean, that is overwhelming. That's 50 people. I mean, how many millions of people are in Los Angeles? Like,
right.
You look at those numbers, it gives you perspective. It does not take a lot to really tax our system. Yeah. We're not geared to everyone getting sick at one time.
Right. Absolutely. Absolutely. Well, great. Is there anything else you'd like to say?
You know what? This is a very fluid situation. You know, like, this is a novel virus. It's like we're learning a lot about it, you know, all the time. So, and sometimes the messaging is unclear, and the lack of clarity is because we're learning more. And what was true like 2 weeks ago may not be true like today or tomorrow. So that's one thing. Information is definitely helpful. What we do know so far is like this social distancing, this staying at home absolutely works. And I have no doubt that if people did not do anything, completely isolated for a short amount of time, this thing actually will start going away. And that continues to be very, very important.
Yeah. Well, thank you so much, Dr. David Ng. I feel so blessed to have had this time with you. Thank you so much for breaking away from all the important work that you're doing to do this. But I think it's an important message, and we have, like I said, tens of thousands of listeners in Los Angeles that will hear it and spread the word, hopefully. Thank you so, so, so much.
My pleasure. Everyone be safe.